Okay. Tomas, you're going to talk about registries in Sweden. You've had a build-up that no one could deny. Swedish registries are by far the best. They are absolutely wonderful. We know you're not going to disappoint us.
Okay.
Anyway, you're the cardiologist, so you're going to talk about one specific registry about cardiology. So we'll hand the floor to you.
Okay, thank you. I will talk about improvement by the use of nationwide cardiovascular quality registries, and I will use the Swedish registry SWEDEHEART as an example. And SWEDEHEART was started in 2009 and it's really a merge of 5 different registries, of which 3 registries were started in the early 1990s. So they are more than 20 years old. And these are the registry of acute coronary care, the registry of angiography and PCI, heart surgery registry, and then we have the registry of secondary prevention, which is really an extension of these 3 registries. And then we have a new one, the registry of catheter-based valve intervention. It is very important to note that this is a bottom-up organization. All important decisions are made by the users, by the hospitals at annual meetings. And all the members in the working groups are elected by the users. And the chairman of the working groups constitute the SWEDEHEART steering group. And SWEDEHEART is funded by the public healthcare providers. And then we have a registry center that helps us make the whole thing work. And the reason for the merge was that we wanted to keep the whole process of care together. So if a patient is admitted with a myocardial infarction and then undergoes angiography and then perhaps a bypass surgery and then is followed for secondary prevention for up to 1 year, all data can be entered into one web-based case report form. And we also wanted to avoid redundant entering of the same data into several different registries. All hospitals in Sweden participate in SWEDEHEART, except for the secondary prevention part. We still have a few hospitals to convince. On a patient level, we have a 100% coverage regarding intervention. But regarding myocardial infarction, we are still missing some patients, mainly elderly patients and patients with small secondary myocardial infarctions. And we include about 80,000 cases each year, about 20,000 cases of myocardial infarctions, 40,000 cases of angiography or PCI, 7,000 cases of heart surgery, and we are following 6,000 patients regarding secondary prevention. And altogether, we collect more than 500 variables, mostly baseline data, process and outcome measures. We have 7 monitors traveling around the country, monitoring all the hospitals on a regular basis, and we have a 95 to 96% agreement between patient records and the registry. And the whole system is web-based, and all data are entered online by the caregiver into the system. And the system provides online reports, both regarding outcome and also performance measurements immediately. So it's really online reporting. And the hospitals can make comparisons over time and with other hospitals. We are working very hard trying to be able to export data directly from the patient electronic records into the system, but still only one hospital can actually do that. But we think that within 1 or 2 years, 1/3 of the Swedish hospitals will be able to export data directly from the electronic patient records into the system. And each year we merge the SWEDEHEART database with other health registries, creating a very useful research database. And this is how the data entry page looks like. All data must be very easy to enter, and we have, for each box, we have a help text. And when you are working with the system can also provide you with previous history of the patient. Here, for example, the operator can see what kind of stents the patient has previously got, and the operator is asked whether these stents have restenosis and whether they are occluded or not. And we publish every year. We publish an annual report, and we also have an English version that can be downloaded from our website. And in these reports, we report about changes over time regarding both different kind of treatments, but also regarding different kind of outcomes. And we do a lot of benchmarking between regions and between different hospitals. And we do it always. We do it openly like this, with the names of the regions and the names of the hospitals. But if you really want to support improvement, I don't think annual reports will do. I mean, caregivers, they need immediate access to online reports to see how they are doing at that moment. And this is an example of an online report where the caregiver can compare themselves here with other hospitals in the same region, with other hospitals in the country, and these are 9 different quality indicators. And the caregivers also want to know changes over time, and this is just one example again. It's a quality indicator, and you can see how it looked like before and after the intervention, education, or organization change. And this is perhaps the most important part of my speech, and that is that RIKS-HIA quality index is a very good example how a quality registry really can stimulate improvement. RIKS-HIA quality index started in 2005 and summarizes the quality of care at a hospital by using 9 different quality indicators. Each indicator has a high level of evidence, and we have done an extensive short review in several hundreds of patients just to come up with the proportion of patients who really should have this kind of treatment. And if the hospital reaches this level, they get 1 point, and if they are close to it, they get half a point. So the hospital can get up to 9 points with this quality index. And we have been publishing this index openly like this with all the names of the hospitals since 2006. I think we have done it openly like this. And RIKS-HIA's quality index has got a lot of attention, both from the profession, but also from policymakers, politicians, and of course also from the public. And this has really stimulated hospitals to work with their quality. And during the last years, you can see there have been an amazing improvement in quality. So if you look, a hospital that had 4 points 2005 was one of the best 10 hospitals in Sweden. A hospital that had 4 points 2011 was one of the poorest hospitals in Sweden. So you can see that we have had an amazing improvement in quality. And we can also see that this, you can see the quality index on the y-axis, and here you have the years. You can see that the improvement started to accelerate when we started to go public. And especially in the poor performing hospitals, you can see that they started really to improve when we went public with the results. And more people started to discuss it. And the question is, can we translate this improvement regarding performance measurements into improvement in outcome? And I would say yes. This is again data from SWEDEHEART from 1995 until 2007. And here you can see the development of 6 different evidence-based treatments. And the black line is the median, and the gray lines are individual hospitals. And you can see that there have been an improvement of all these 6 treatments, but you can also see that the variation has been quite large, especially in the beginning of a new treatment. And if you look at the mortality during the same time period, you can see that the mortality has decreased, the in-hospital mortality from 12 to 5%, the 30-day mortality from 14 to 7%, and the 1-year mortality from 21 to 12%. And perhaps you are thinking that this is because these patients are healthier with smaller infarcts, but that is not the explanation, because when we adjust for changes in baseline data, we can see and look at the standardized mortality, we can see the same trend. We have not been as successful regarding secondary prevention. This is lifestyle changes 1 year after an acute myocardial infarction in patients younger than 75. You can see that about 50% of the smokers have quit smoking after 1 year, but you can also see that there is a great variation between the hospitals. Also the same regarding participation in exercise programs. About 40% of the patients have participated, but again you can see a very great variation from about 70% down to 0%. And the same, you can see the same variation regarding how physical active the patients are. Again, if we look at the proportion of patients with systolic blood pressure below 140 after 1 year, you can see that only 2/3 of the patients fulfill this requirement. And you can see again a great variation between the hospital, and the same regarding the LDL cholesterol. And we have tried to use a quality index also for secondary prevention. We call it Q4, and that is the proportion of patients who don't smoke, have participated in exercise programs, and have a systolic blood pressure below 140 and an LDL cholesterol below 2.5. I don't think this is really asking for too much, I think. But if you look at the results, only 19% of the patients fulfill this requirement. And if you look at the hospitals, you can see that some hospitals have more than about 40% of the patients fulfill this requirement, whereas other hospitals have 0%. 2 more slides. This is another example how quality registries can improve quality, and that is to look at also medical technical products. Stents are deployed in coronary artery disease to keep them open, but a feared complication with stents is stent occlusions, and the mortality is about 30% when that happens. We have continuously published these data regarding the risk of stent occlusion with different stents on our website. These are unadjusted data, and these are adjusted data. And as you can see, there are some stents that are not as good as others, and these stents are no longer used in Sweden. So in summary, nationwide cardiovascular registries can ignite improvement by including almost all patients, not selected cases, not selected centers. collecting data with a high degree of validity, providing the users with online reports for comparisons over time and with other hospitals regarding both performance and outcome measures, providing policymakers, politicians, and the public with balanced information regarding the quality of care, providing indices that summarize the quality of care to stimulate improvement, and evaluating new drugs, medical technical products, and treatment strategies in reality, and also being used for registry research. Thank you.
Thomas, thank you very much. What absolutely stunning data. I mean, it is impossible to argue against public disclosure of data in that context. It's absolutely wonderful. Thank you very much for sharing that with us. Now, have we any questions? Yes, we have 2 questions. VG, thank you very much. Can I just, while we're waiting to go there, Thomas, can you flick back to the slide with the variation in results for STEMI? Because what I thought was absolutely amazing.
Which one?
Yeah, that one there. Can you just, because it's quite hard to see the variation, can you explain that just to people who are even further back than I am? Because the variation is absolutely amazing. I mean, how...
Yeah, I mean, if you look at the variation regarding the use of acute PCI, I mean, here we knew that primary PCI was the best option, and we can see that it always takes a while for a new method to get going in clinical practice. But as you can see, there is a great variation how quickly hospitals implement new knowledge.
Yeah, if you just run that green light along the outliers on either side, because just to show the range there. I mean, that's the range, and at the other end, I mean, it's a stunning range. Yeah. I mean, unfortunately, I'm at the age where I'm likely to be on one of those statistics. So, I mean, if I saw that type of statistic, goodness me, would it change your practice or change? Would you as a patient have a lever on your hospital? It's absolutely incredible data. Yeah, fantastic. So thank you very much. Now, sorry, where is the question now?
Yeah. Actually, first my compliments for your presentation. It gives an excellent example how to use your data, and that's also my question. And from the healthcare inspector bureau, indicator system like that, and we found out that the main problem isn't collecting data or defining data, it's using data. Asking the right type of questions. And actually, that's also my question. How do you set the questions that you ask your database to use to get to these type of outcome measures?
Can you repeat the question? Could you repeat it?
How do you come to these questions to ask, to look at these types of elements from your registry?
Okay, I mean, we usually look at our national guidelines. I mean, we start looking at our national guidelines and see if they are in adherence with those guidelines. Regarding performance measurements, I mean, regarding outcome measures, it's easy. Better, I mean, lower is better.
So you start with your guidelines, and then those provide the questions that go into your registry. Am I correct?
Yes.
Okay.
Okay, we'll have just 2 quick questions. There's someone over there, VG, and I have a question here in front of me.
Go first. Okay. If you see the variation there, do you ever go back to the centres and ask them what they're doing, or study in a formal way the processes and outcomes in operation in each centre to understand the variation and then use that as a change package?
I mean, we are discussing it. I mean, if we see these hospitals who are doing, I mean, not as good. I mean, we have these meetings discussing this. I mean, so we always, when we have a great variation, we have meetings discussing it, and so I think those hospitals who are down here, they understand that here is something wrong with us. Yeah.
Thank you. And the final question, just before we break.
Yes. I'm one of those people that Dr. Burgess referred to earlier, who ran a registry for a professional society in Britain for some years. And in Britain, our Department of Health's attitude has always been that it's too expensive for government to fund these registries, and as a result we have professional registries which are run by amateurs like myself and often full of holes. So my question's about cost. Do you have any idea how much the entire registry system costs in Sweden as a percentage of your health budget?
No, I don't have an idea how much it costs, but I'm very sure it's worth it.
I agree.
On that note, we'll finish. Look, I'm really sorry. We could be here all evening. It's absolutely fascinating. It was wonderful. Can I ask you to thank, of course, our AV technician, Dave, who's been here heroically all day, Fiji and Teresa, who have been fantastic, and, of course, our absolutely superb speakers. Thank you very much, folks.